Now, if your mother happens to have gestational diabetes and you're born fat, my gosh, the prevalence of metabolic syndrome is almost tripled over the control group. But very importantly, notice that if you were born to a mother who had gestational diabetes, but were born normal sized, the likelihood at age 7 to 8 of having the metabolic syndrome was roughly equivalent to being born to a mother who didn't have diabetes, suggesting that interventions during the pregnancy may make a difference, perhaps a lifelong difference. And here is, at age 27, offspring of children who are offspring of mothers who were either normal, in the purple bars, had type 1 diabetes in the green bars, gestational diabetes in the blue and the reds. So let's pick a couple things to look at. Let's look at the metabolic syndrome, that hypertension, hyperglycemia, hyperlipidemia, metabolic syndrome, and look at, now if you're normal, a fairly low rate of this. If your mother had type 1 diabetes, it doubles the risk of the metabolic syndrome. But look, if your mother had gestational diabetes in poor control, it's even worse than having type 1 diabetes. Or over here, look at these 27-year-olds and look at their fasting blood sugars over 100. These are people with pre-diabetes, 27 years of age. And look at the spread in what their glucose values are depending on whether their mother did not have diabetes or had gestational diabetes in poor control. Really suggests that interventions by you and me for mothers with hyperglycemic issues could make a difference downstream, perhaps for a lifetime. In fact, it's been described as the intergenerational transfer of obesity. If I have an obese mother who also happens to develop gestational diabetes, she is going to give that disease to her children, not after they're born necessarily, and not necessarily because of their genes, but possibly because of the way she eats and her blood sugars are managed during pregnancy. So this just reminds us that we have a placenta separating a mother and a baby, and whatever glucose happens on the mother's side is going to be seen on the fetal side. Now, the fetus doesn't have an insulin resistance problem, has good insulin secretion, and will take all this tide of glucose that comes flowing across the placenta and store this in the body as body fat. Remember, diabetes, high blood sugar does not make a child's head grow big. It does not give a long leg, a long baby. No, it just makes a baby with central body fat. And that's what we're talking about right here. Furthermore, we know that all these extra calories coming across the placenta require work to store. And that uses up oxygen, so that every baby, when they're dealing with a glucose load here, will drop its oxygen inside its mother's compartment while it's, if you will, doing an anaerobic workout, trying to store all this glucose. And that probably is the key event that leads to hyperviscosity, hyperbilirubinemia, cardiac remodeling, and possibly metabolic programming to become obese and diabetic downstream. All right, so the question is, and here you see a Time magazine thing, can the first 9 months shape the rest of your life? And can an intervention make a difference? So we have 2 randomized controlled trials that have examined this, and one was done in Australia and New Zealand, the so-called A-Choice study of treatment of gestational diabetes, and saying, hey, you know what, this is back in 2005, let's pretend gestational diabetes isn't a disease. And we'll randomize people who qualify it based on these lab tests to either treatment or no. And look at it. Here we go. Here are the patients who got no treatment. And here are the patients who had the intervention, and which is you're familiar with, which is dietary measures, and if that fails, going on to medication. Here's the difference in the birth weights. Not too impressive. In fact, it's less than 100 grams, statistically significant. Okay. However, look at the marked difference in the fat babies, the large for gestational age babies, more than 90th percentile for expected weight. Cut it almost in half. Weigh more than 4,000 grams at birth, cut it in half, and the incidence of maternal preeclampsia, which we do know is related to maternal glucose levels, is cut by 1/3. Amazing differences. from this intervention, suggesting that, yeah, treating gestational diabetes probably makes sense. The next study is by Mark Landon and the NIH Maternal Fetal Medicine Network, and instead they said, okay, that's the Australian study. They treated all these people with pretty heavy-duty gestational diabetes. Let's just take the people with normal fasting, but 2 abnormal values on their 3-hour test, and let's see if they need treatment, because maybe we can let them out of the, let them not get treated. Well, here's the results. The birth weight differences, modest, about 100 grams. The birth weight more than 4,000 grams, however, dropped by 2/3. Large for gestational age, cut in half. And neonatal fat mass, markedly decreased, while there was no difference in prematurity or small for gestational age and so forth. So there's no question that even taking the mildest form that we presently diagnose with gestational diabetes and treating it makes a difference. At least it makes a difference up to the point of birth. By the way, in this study, in the U.S. study, there was a marked difference. There was a significant difference in lowering of cesarean rates and a lowering of shoulder dystocia rates. No difference in birth injury, not enough patients in the study, but definitely a difference in shoulder dystocia, suggesting it is making a difference in the way the body mass is distributed in these children as they're born. Okay, well, if treatment of gestational diabetes is beneficial, whom should we treat? Should we treat only the high-risk patients? Should we treat everybody who's possibly at risk? And this is the vexing problem that I will say at the end of the lecture. You'll have to say, oh, I wish we knew. And so here's a question for the audience I'd like to know. In your practice, and if your practice involves quite a few different providers and practices and so forth referring to you, just tell us about the majority of the patients you see. Are they diagnosed using the 2-step test, the 1-step test? And remember, the 2-step test is the 50-gram glucose challenge followed by the 3-hour test, and the 1-step test is a 175-gram 2-hour test. Or are they using both? You can answer, please, in each of the 3 categories, and we'll total them up and let you know what we got.
23% are using the 1-step, 28% are using the 2-step, 26% are using both, 10 aren't sure, and 13 it is not applicable to them.
Statement of oh man, that summarizes our situation exactly. So let's plow through, because next we're going to talk about what American College of OB/GYN, the National Institutes of Health, have done for us, and I can see why we're straddling the 1-step, the 2-step, the both step, the no step. Let's see how it goes. Let me back over here. Okay, so a little bit about the 3-hour test. And people who have been in the business for a while know that the numbers that we have to memorize have migrated along. And I'm old enough to remember the 105, 190, 165, 145 numbers that came out from ADA back in the 80s. However, Carpenter and Kustin appropriately reminded us that we no longer do whole blood glucose. Now we use capillary or glucose or plasma glucose, and the numbers needed to be lower. And these are probably the numbers that you're using, is the 95, 180, 155, 140. And you make the diagnosis by having 2 values that meet or exceed the numbers that you see here. And that is the standard diagnostic test. So that would be one thing, but remember, we don't make every pregnant woman take that 3-hour test. Why? Because it's a long test. Secondly, it's an expensive test. Thirdly, a lot of people throw up with the 100 grams of glucose that's in that test. So people have tried to figure out ways to shortcut that, and that takes us to the glucose challenge test. Well, let me just go over the 75-gram glucose test. So you can see we have World Health Organization at the bottom here, the Canadian Diabetes Association, a lot of different ones, and they've used kind of different numbers in terms of, for example, what's allowable for the fasting. Is it 126, which is the diagnosis, by the way, of type 2 diabetes, according to the American Diabetes Association? Or is it 95, that's used by the Canadians, which is kind of a more reasonable value, or 100, which is used by ADIPS, which is the number that's the low number for pre-diabetes? I don't know. And how many abnormal values do you need? Mostly, it's usually 2 abnormal values unless the 2 hours over 200. Is that simpler than the 3-hour test? Hard to know. The only advantage of the 2-hour test is it's a one-step. You give it at one shot and you're done. So where do we get these things? Well, just to remind ourselves that this was invented back in the 50s by O'Sullivan and Mahan, who were simply trying to figure out which women would develop diabetes later in pregnancy, later in life. And they set up this 3-hour test, which was used to diagnose diabetes, and they simply took the top 3% and said that was abnormal. And those numbers that you see and you're using today, if you're using the 3-hour test, were derived strictly on the likelihood, the top 3% of the blood glucose responses that predicted a high predictive value, like 50% of women would develop type 2 diabetes within the next 5 years. And so this is really a test of mother. It doesn't tell us anything about baby possibly getting fat. It just tells us about mothers getting diabetes later in life. Is that really the test we want to use today? And what's wrong with using a 2-step test? We've been using it all this long. Why do we need to change it? Well, for one thing, you can see that if you use 140 as the cutoff for the challenge test. So remember, first we administer the challenge test. If you flunk that, then you go to the 3-hour test. If you use 140 as the cutoff, because remember, if you sneak through and you got 138 on your glucose and using 140 as the cutoff, then you don't have it, right? No, that's not true. 20% will have it, and the test will be normal. Oops. And 10% of the people will who take the test will end up having to do the 3-hour test. Okay. Now, if we use 130 as the cutoff, we will pick up 90%. That means even with 130, 10% of women will, if you will, slip through, be called normal, but grow a fat baby during the pregnancy. And we will double the number of patients who have to do the 3-hour test. So, what are we going to use? 130, 140. Wait around. Here's another little confusing factor. This is from the California Sweet Success Program. And the bars represent babies of various birth weights. So the yellow bars are babies that weigh more than 10 pounds. The red bars are babies that weigh between 9 and 10. And they, by the way, the bluish ones weigh less than 6 pounds. Now, the categories here are, let's focus on the type 1 diabetes over here. So these women got real-on diabetes, and you can see that around 15% of patients have babies between 8 and 9 pounds. If you add the yellow bar into the white bar, you're up to about 20% of women with type 1 diabetes will deliver a baby that is obese. Okay? Notice that it's not quite so severe if you take the women with gestational diabetes, because they had 2 abnormal values on the 3-hour test. If we put the yellow bar on top, we're going to end up with about 12% being obese, the newborns being obese. Okay. Now look at, who are these people? Impaired glucose tolerance. These are women who had 1 abnormal value on the 3-hour test. They were told, don't worry, your test is negative. When I put that yellow bar on top of that red bar, in fact, 15% more than even this group who got treatment. These people got no treatment. They have more macrosomic babies than this. Maybe we're not treating everybody we should be treating.